can all stay healthy, and no one suffers from hunger. We will only realize this vision together. Together, we will come back stronger. Together, for a future with health for all, hunger for none. One day, we can all stay healthy, and
my journey continues, and I know I'm not alone. Because together, we can make a difference every day.
Yes. Okay, so welcome to the section today. We have a section about imaging-assisted cardiac intervention, except for TAVI. I'm Dr. Nguyễn Ngọc Tráng from Bạch Mai Hospital, Vietnam. As you know, for the schedule, Associate Professor Phạm Mạnh Hùng will be the chairperson, one of the chairperson of this section, but due to the urgent situations, so I will replace Professor Mạnh Hùng today. And I'm very honored to introduce my co-chairperson, Professor Jin Ho from Korea. And Professor Jin Ho also a speaker in our section today. And today we have four speakers from Dr. Zhang Yin Jiang from China, Associate Professor Hoàng Anh Tiến from Vietnam, Professor Jin Ho from Korea, and Associate Professor Sung Ho Wang from Korea. So now I would like to transfer the microphone to Professor Jin Ho to present the two first speakers. Please, Professor Jin Ho.
Thank you, Dr. Trang. Good morning, everyone. Good to see you. My name is Jin Ho, and I'm a professor of Yonsei University Severance Hospital. It's my great pleasure to join this session as a co-chair chairperson. So let me start with our first speaker. It's my great pleasure to introduce our first speaker, Dr. Zhang from China. He's currently a professor of Shanghai General Hospital of Shanghai Jiao Tong University. He wrote many valuable research papers in excellent journals, including radiology. So he will give us a talk about pre-procedural imaging of CTO lesions from anatomy to function. So please, Dr. Zhang.
Dear Asci members and colleagues, I'm Dr. Zhang Zhang from Department of Radiology, Shanghai General Hospital. It's my great honor to give a talk on the pre-procedural imaging of coronary total occlusion from anatomy to function. I would like to share my talk in the following three parts. So let's first take a look at the pathological features of coronary total occlusion. What is coronary total occlusion? It is defined as the complete blockage of the antegrade blood flow that is what we call the TIMI grade 0 on invasive coronary angiography, and the clinical duration is longer than 3 months. Right coronary artery is the most common site to be seen for coronary total occlusion, followed by left anterior descending as well as left circumflex. CTO is frequently encountered in coronary artery disease patients, especially for those with concomitant diabetes. And for patients with coronary total occlusion, majority are symptomatic, either with stable or progressive angina. And for histopathological findings, the early stage of CTO, what is less than within 1 year duration, has intensive inflammation response as well as macrophage infiltration. And for the early stage, the component is usually composed of protein glycan-rich matrix, which is soft and easy for the guide wire to cross. And for late stage of CTO, the collagen and elastin-rich matrix replace the protein glycan-rich matrix, and the collagen is relatively hard and difficult for the guide wire to cross. But it is notable that microvessels, or what we call a recanalized lumen, can be seen usually in the late stage of CTO. This is the baseline and follow-up imaging of one CTO lesion. And for the baseline, the right coronary artery CTO lesion has more low-density components. That is the blue part. If we take a look at here, it is accounting for less than 50%, approximately 50% of the total lesion. However, when the disease progressed to the late stage, the low density component is now only accounting for less than 20%. And for the rabbit animal with coronary total occlusion, it reveals the microvessel formation within the occlusion, and those microvessels diameter varies from 100 micron to 500 micron. And for those recanalized lumen, the diameter can be as large as 500 micron to 1 millimeter. And as shown on the right, that case showing a spontaneous recanalization of the right coronary artery. If you take a look at the for the baseline imaging, the distal right coronary artery has a complete occlusion. However, 2 years later, those occluded segments had a spontaneous recanalization. So for the imaging of CTO, as it is regarded as the most difficult lesion for percutaneous coronary intervention, with higher rate of complications, longer procedural time. So the image-guided PCI may optimize the physician as well as the patient's benefit. So we not only have to evaluate the vessel anatomy, but also for functional aspects such as the myocardial ischemia and viability. For anatomical evaluation and the treatment guidance, let's first take a look at the case of the CTO of proximal left circumflex. If we look at the contralateral invasive coronary angiography, the distal filling is can be vaguely seen because there is scattered contrast filling of the distal vessels. So the precise occlusion length and the precise occlusion course cannot be evaluated solely on the invasive coronary angiography. But on the CT coronary angiography, the whole course of the occlusion can be seen with if you take a look at here, this is the distal filling, although it is not as intense as other segments of the left anterior descending. However, we can be very confident that those segments, they are patent and not part of the occlusion, and the accurate proximal cap and distal cap of the occlusion is as indicated by the arrowheads here. So this is the advantage of coronary CT angiography for CTO imaging. It can precisely identify the trajectory of occlusion segment and allows for accurate estimation of occlusion lengths and distal segments, and also provide the intraluminal details such as the calcification, the occlusion component density, the remodeling, as well as the recanalized lumen. However, due to the limited spatial resolution, CT coronary angiography is unable to accurately visualize the collateral connection as which can be seen on the invasive coronary angiography. And the following parameters are those what we need to evaluate on the coronary CT angiography for CTO lesions. The first and the most important parameter is the occlusion length, as it is the advantage of CTA to measure the occlusion length, whether it is longer than 2 cm or less than 2 cm. And the second parameter is calcification. For those calcification, more than 50% of the cross-sectional area, that is what we call the severe calcification, and may hamper the balloon crossing and leading to a failure of the PCI for coronary total occlusion. And other parameters, including the stump morphology and occlusion course, can also be accurately evaluated on CT coronary angiography. And also the epicardial collateral connection can be precisely visualized on CT. However, the septal collaterals, as they are usually less than 1 millimeter, so sometimes it can be visualized, but sometimes it is very difficult for the CT coronary angiography to evaluate the septal collateral connection. And this is the distal filling of the coronary total occlusion as evaluated on CTA. That is, absence of the distal filling. There is no contrast filling distal to the occlusion, and poor distal filling. As you can see here, the distal segments can only be vaguely seen with partial contrast filling, and this is the partial distal filling. Some parts of the distal segments are completely filled, but other parts of the distal segments are only partially filled. And this is the complete distal filling. That is, the all of the distal segments are well filled by the contrast medium. And another feature, anatomy feature, is the microchannel or the recanalized lumen in the occlusion. As you can see here, on invasive coronary angiography, it does not show any recanalized lumen either on the ipsilateral or contralateral invasive coronary angiography. However, on the CT coronary angiography, as you can see here, it suggests a very large spontaneously recanalized lumen within the occlusion. And this large recanalized lumen usually indicates this CTO lesion is not so difficult to be recanalized. And for the complexity evaluation for CTO treatment, initially the JCTO score was proposed based on the invasive coronary angiography to evaluate the successful rate for the procedure and the successful rate for guidewire crossing within 30 minutes. However, according to this previous study, it shows that the CT-based JCTO score outperforms the invasive coronary angiography-based JCTO score to predict the procedural success as well as the successful guidewire crossing within 30 minutes. So it is mainly due to the more accurate and precise evaluation of those CTO anatomical feature, especially for the occlusion length, which is usually overestimated on the invasive coronary angiography. And this is one example of how we assess the complexity using CT-based JCTO score. If we zoom in, here you can see the proximal stump is tapered, and there is spotty calcifications with no calcification accounting for more than half cross-sectional area, and without more than 45 degrees bending, and the occlusion length is 33 millimeter. That is more than 2 centimeters. So we give 0.1. Could give 1 point, and this is not a retry lesion. So the total JCTO score is 1 point, suggesting a intermediate lesion. Other CT-based anatomical scoring system have been proposed, such as CT rectal score or KCCT score. The fundamental parts of those two score systems are similar to the JCTO score. However, it adds several other anatomical features, such as whether the presence of a multiple occlusion is presented, or a the severe calcification, that is the calcium accounting for more than half cross-sectional area, or accounting for the more than 180 degree of the vessel ring. And this is the clinical evidence of how CTA can help the PCI for CTO lesions. This is the most recently published data, the CT-CTO trial, which is a randomized multicenter clinical trial. There are 200 cases of CTA plus invasive coronary angiography guided PCI versus another 200 cases of only invasive coronary angiography guided PCI. And CT guided PCI yielded higher success rates, especially for those complex CTO lesions, which is defined as JCTO score at least 2 points. And there is no significant difference regarding the complications and outcome between two groups. And also we can use the CTA and invasive coronary angiography image fusion to guide PCI. It is especially helpful to guide a guide wire direction into the proximal cap in those complex CTO lesions. For differential diagnosis of CTO on coronary CT angiography, sometimes we have to distinguish CTO from subtotal occlusion. This is the reverse attenuation gradient sign. For CTO lesions, because the distal segments are usually filled by the contralateral collaterals, so there is a increased attenuation gradient as the from the proximal to the distal part of the distal segments. And in contrast, for subtotal occlusion, because the blood flow, the direction of the blood flow is antegrade, so this reverse attenuation gradient size will not be seen or observed in the setting of subtotal occlusion. And another circumstance is the competitive reverse flow. You will see a sudden attenuation drop distal to a severe stenosis with the presence of reverse attenuation gradient. But however, it is not a true occlusion, because there is no lesion can be seen at the interruption of the antegrade blood flow, and this is only due to the low pressure secondary to the proximal severe stenosis, and it will be automatically spontaneously regressed once the proximal severe stenosis is successfully recanalized. And another differential diagnosis is the alcapa, especially the adult type. The left coronary artery, as you see in this case, originated from the pulmonary artery trunk, and there is a remarkable dilatation of right coronary artery with diffuse collateral connection between the right coronary artery and the left coronary arteries. And the symptom of those L kappa patient with L kappa is typically is as same as the ischemic cardiomyopathy, and the differential diagnosis. The diagnosis is easily to be made on the coronary angiography, but sometimes can be difficult on the invasive coronary angiography. And the last part is the functional assessment of coronary total occlusion. According to the American as well as the European guideline, the revascularization of coronary total occlusion is considered appropriate only in the presence of viable myocardium. For functional assessment, we usually use cardiac magnetic resonance imaging to evaluate the left ventricle function, the myocardial perfusion, as well as the most important part is the myocardial viability. Because as we already know that the scar transmurality is closely associated with the systolic function improvement after the revascularization. And according to several previous studies, for this one, the heart failure patients with coronary total occlusion and ejection fraction less than 40%, PCI may improve the LV function in the presence of viable myocardium. And similarly, another study showing that the CTO lesion with less than 75% thickness transmurality scar, PCI improves the LV function as well as myocardial perfusion reserve. And for the relationship between the collaterals and the myocardial infarction, it is according to this study, it is considered that the well-developed collaterals usually has less scar extent. However, the overall rate of the dysfunctional segments plus the transmural infarction is low in both well-developed collateral group and the poorly developed collateral group. And similarly, as I have previously mentioned, CT coronary angiography is also helpful for collateral classification, and for well-developed collaterals, that is collateral score, CT collateral score, 0.3 has a lower rate of myocardial infarction and low rate of transmural myocardial infarction. As you can see here on the left, complete distal filling of the distal segments, and there is absence of myocardial infarction. And for this CT lesion of the middle left anterior descending, the distal segments are poorly filled, and there is a transmural infarction here. And for the comprehensive evaluation of CTO, as in this case, multivessel disease and the CTO of the left circumflex, the CMR showing this function of the lateral wall and reversible myocardial ischemia of the lateral wall, and there is approximately 50% transmural myocardial infarction scar can be observed. And on the left, there is a distal coronary total occlusion of the distal right coronary artery. However, there is no evidence of myocardial scar, so this lesion is a revascularized candidate for PCI. And in contrast, another CTO for the distal right coronary artery, there is a transmural scar and no viable myocardium in the subtended territory, so it is not a candidate for PCI. And in addition to CMR, CT myocardial perfusion imaging plus CT coronary angiography is also showing the potential for one-stop shop imaging for anatomy, perfusion, as well as the viability. As you can see here, there is a complete occlusion of the distal left circumflex, and there is a myocardial ischemia in the it's within its territory, and there is a transmural myocardial scar presented here. And similarly, for the CTO of middle left anterior descending, there is a diffuse myocardial ischemia of the anterior LV wall. However, there is only small foci of myocardial scar within the ischemic territory. So it is a strong indication for revascularization treatment for this LAD CTO lesion. And there is some other new findings, such as the high density signal intensity on MR angiography, which may indicate the PCI success because the authors hypothesize that the higher signal intensity on MR angiography may relate to early thrombus and the neovascularization, which is relatively easier for guide to cross. And similar finding can be seen in another previous study, that is higher signal intensity on T1 weight image black pool can be seen in the early stage of coronary total occlusion. And to summarize, the coronary total occlusion, chronic total occlusion, is a relatively difficult lesion for PCI treatment. So imaging guiding PCI is helpful to improve the patient's outcome and enhance the successful rate. We have to evaluate not only the anatomical but also the functional aspects to optimize the benefit of both physician and patients. And thank you for your attention.
So thank you, Dr. Zhang. This lecture was very informative to understand what CTO lesion is and what is imaging role for CTO treatment. After all 4 lectures, we will have a Q&A session. And let me introduce our next speaker. So the next speaker is Professor Hong An Tien from Vietnam. Professor Hong An Tien is currently Vice Director of Cardiovascular Center and Vice Head of Cardiology Department of Hugh University Hospital. He is a member of European Society of Cardiology and also a member of Heart Rhythm Society. He published many valuable research papers, and he will give us an interesting talk today about artificial intelligence in interventional radiology. So please, Dr. Hong An Tien.
Good morning, Chairman, audience, ladies and gentlemen. Today I would like to introduce my topic, artificial intelligence in calories. So the first, I would like to introduce about topic, artificial intelligence applications like clinical decision support system can prompt application of evidence-based calories in clinical practice. It's a computer system that deals with the clinical big data and European Society Calories Medical Knowledge guidelines, and is intended to prove the decision support. Artificial intelligence and super brain training by USA guidelines and appropriate use criteria integrated with specific cases book the correct decision support in the clinical workflows context. About overviews of artificial intelligence. As you see, artificial intelligence has a lot of applications. For example, natural language processing, speech system, planning, medical learning, machine learning, robotics, speech visions. The positions of artificial intelligence. The field of artificial intelligence has initiated a paradigm shift in the healthcare with advanced analytical techniques. Potential applications of artificial intelligence in interventional calories are image, video analysis, clinical decision support, robotics assistance with procedure, and novel approach to clinical database analysis. The current development of artificial intelligence in interventional calories is in its early stage, but it has potential to transform interventional calories practice. About the evolution of artificial intelligence, as you see, the base are the assist intelligence. The nature of tasks don't change. Tasks are automated. Humans don't learn. Machines learn. The next level is the augmented intelligence. Nature of tasks change. Human inform machines. Machines inform human. And the highest level is the autonomous intelligence. Nature of tasks change. Decisions are automated. Machines learn continuously. About the application of artificial intelligence in interventional cardiology. Application of artificial in interventional cardiology, as you see, here's the artificial intelligence, machine learning, deep learning, and here is machine learning, for example, big data research, predictive analytics for personal therapies, disease stratification, deep learning, for example, spec level, interpretation of angiographies, IVUS OCT clinical outcome predict, and CT FFR. The natural language processing, for example, data extraction from art and virtual assistant. Cognitive computing, for example, automatic clinical decision support in clinics and characterization laboratories, computer vision, for example, acquisitions and interpretation of image include computers as diagnostic and image guide procedure and year-based apparatus. Robotic automate a semi-automate a cardiovascular robotic system. Here's the sample of machine learning. Here's the app from the ACC and AAS, American College of Cardiologists and American Heart Association. That's the app for the mobile application. And here, after we input the age, gender, race, the cholesterol, systolic blood pressure, diastolic pressure, and this app can calculate the estimated risk for the 10 years atherosclerosis cardiovascular disease. And after we have research, this app can give the treatment advice summary according to the ACC recommendation. And here's the sample for the neural network. And here we'll see the computer vision, for example, coronary angiogram, and the mission for the auto-recognized coronary artery. And here, in the center, is a deep learning for the medical image segment. And the other component is the vessel segmentation and OpenCV. Algorithm for coronary artery stenosis evaluation. Here, you can see the process after we do the coronary arteries angiography. Here's a normalization, here's segmentation, extraction, and so after testing, training, and can get the prediction of the stenosis of coronary artery. Here the sample of deep learning, and here the fractional flow reserve 3 dimension based on coronary angiography. Here the image of coronary angiography, and we use a lot of three dimension, 3 progression, And here we can get the 3D image and flows analysis. And we have with the support from the RE, we can calculate the fractional flow reserve here. And so we calculate the exact number to predict the stenosis of the pulmonary artery. And here another sample of deep learning, the compute tomography scan based fractional flow reserve. After we do the CT scan in this position, we do the angiography, and here we can see the stenosis very clearly. And here we can combine the CT scan, so we can calculate an angiography, so we can calculate the CT-based RFR, and here we can have the result about the stenosis of this position. And here we see a sample of the internal algorithm for automatic reading chorus angiogram. After we use the projection, automatic identification, anatomies, stenosis location, and here the computer vision can capture the image to analyze the most severe stenosis and can calculate the final result of the stenosis. In this operation, the stenosis, the final result is 46.9%. And here's the typical patient pathway for the primary percutaneous coronary interventions device. Here we see at the first step is the natural language processing of patient diagnosis of extracting system. The next is a textbook for the symptom checking. The next is the machine learning, for example, the multi-biomarker algorithm for acute myocardial infarction. Artificial intelligence decision support tool for detection of coronary occlusion. The next is advanced artificial intelligence by EKG, echocardiography, interpretation enhanced with explainability. And the next is the computer vision, for example, fractional flow reserve, estimates from X-ray angiography, myocardial blushing classification, Internet of Things, a smart teacher calorie for activity error logging, robotic to control procedure, and other steps for intelligent well-being algorithm for home monitoring. And here some research. It's a very large study. Is the article registry. Is the stand for artificial intelligence for clinical cardiac navigation. And in here, this study reviews the research about the machine learning technique having used to rapidly integrate large amount of clinical and quantity data to provide patient-based suggestion by clinical decision support system. And here you can see the last part is a CPU, is a central processing unit. The next, the inner is a CPU and the graphic processing unit, and also the field program gate arrays. And the most important, the most smart is the deep learning. It's the many-layer neural network, and it combines a lot of from the CPU, GPU, and FPGAs, and also the ASIC application-specific integrated circuit. And with the result from the article registry, and here we can see about the start time after we apply the artificial intelligence, it can reduce 61 minutes less after we apply artificial intelligence. For the patient, it reduced the very interesting number. 121 minutes after we apply artificial intelligence. So the Arctica research is the artificial intelligence clinical decision support system can approach has the potential to save the cost and the start time in the patient with stable chest pain. Therefore, due to earlier identification, a patient without significant coronary artery disease, the use of unnecessary cardiac imaging tests might be reduced. And these results might have important implications for policy and clinical practice. And here's the trial for the report guideline for the clinical trial of artificial intelligence intervention from the script and consource guideline. And this paper said that efficient identifying the safest and the most effective artificial intelligence in interventions and commissions. Term was confident for the benefits of the patient and the public. About the robotics in interventional cardiology. The applications of robotic in interventional cardiology, as you see very basic. For example, interventional training simulator, microbots, robot system, tele-intervention, supply chain robot, cardiovascular robotics platform. So the future's catheterization laboratory with artificial intelligence enabled. And here we can see the semi-autonomous vascular robot system can perform many procedure steps with minimal assistance from the remote human operation, includes machine learning and computer vision algorithm connect to cloud supercomputer. The augmented reality system is a real-time viewing, measurement, and manipulates for the patient's anatomy in holographic display. For procedures guidance can also display pre-produced image and other elements of medical record. The voice assistant controls and clinical decision support very important to control the system. So here's the coronary intervention with robotic support, and you see with this system, the guidance character controls have the better controls, the maneuverabilities, the guide rail, precise real-time measurement of lesions length, better visualities with the new power visions monitor. And here's the augmented realities cardiac holographic display for procedures guidance, as you see, very impressive. And here's the robotic device with the monitor, with the cassette, is the happening with the robotic. The control station is very safety, very powerful monitor, and so the doctor, the physician can relax with the chairs and stand deployment with this system. Loading the cassette, loading the wire, the balloon, the stand. Here the character. And you see that before the standing, very severe stenosis in the LRD's left anterior descending in this position. And after standing with the robotic assist cardiovascular intervention, after standing, putting one stand in the left anterior descending, and you see after we inflate balloon and we deploy the stand in here, and it can re-establish the flows of coronary artery for the left anterior descending. And Singapore is the first in South Asia to use robot assistant. You see, it's very complicated system. So, advantage of interventional calories with artificial intelligence with this, we can see advantage for the assessed anatomy. It's a close proximities ergonomics visualization. It can precise point and short reactability. About the measure, it's a robotic assist millimeter measurement. The position of the stand, 1 minute precise positioning. The deploy stand, physical device during deployment. So with the robotic cath lab, the shear from the radiation potential to reduce fatigue and orthopedic strain. So the revolutions of tele-interventional calories, you see the same hospital procedure, and we see in a lot of the hospital nowadays, the same hospital control drum, same hospital multi-room controls, and different hospital remote system the revolution is very modern. The cath lab, and we can sit in this hospital, we can control, can do the percutaneous cardiac interventional from the other hospital. So advantage and the channels of artificial intelligence in interventional calories. Advantage is precision, accuracy, data-driven decision on diagnosis and treatment, procedures assistance, integrations, large and diverse information, decrease inner observed and intra-observed variabilities, better in repetitive laboratories, time consumption, time saving, cath lab workflow. The challenge is complexity and cost, lack human trust, common sense, concerns regarding privacy and security, lack large, well-curated clinical or imaging data, circulation data, and threat to human trust. So, conclusions to artificial intelligence on interventional calories. The virtuous applications of artificial intelligence has the potential to enhance the image reconstruction, analysis, and interpretation. Clinical decision support system applies the use of machine learning, natural language processing, and pattern recognition to assist with the imitating human thought processing. The virtual reality platforms are currently being used for various procedures planning of structural heart interventions. Robotics are in their initial phase of application of interventional calories and not like to replace a human interventional calories in the near future. Although they can provide physical assistance, they do not perform intelligent assistance at this time. Artificial intelligence is poised to transform and enhance the practice of interventional cardiology. Thank you for your attention.
Thank you so much, Professor Hoàng Anh Tiến, for your nice presentations of our AI in interventional cardiology. So we come back, if we can have time, we can come back with the Q&A discussion later. So up next, I would like to introduce the next speaker, Professor Jin Ho from Yongsan, Korea University, with the topic for LIA occlusion in the emerging assistant. And Professor Jin Ho now working at several hospitals, Yongsan University College of Medicine, and he have many awards and honor, and also published many valuable publications. So now, Professor Jin Ho, please.
Good morning, everyone. My name is Jin Ho, and I'm a professor of Yonsei University Severance Hospital from South Korea. Today, I would like to spend the next 20 minutes talking about how we can perform LAA device occlusion using imaging guidance, and what is the imaging role in pre and post procedure for LAA device occlusion. Today, I hope to cover the following topics. First, I will give you a brief introduction on the clinical indication and techniques of LAA closure. Then, I would like to talk about the clinical applications of cardiac CT for pre and post-procedural imaging. And at the end, I will briefly cover the considerations for cardiac CT imaging for the clinical applications as pre and post-procedural imaging. Let me start with this case. Here is a case of a 70-year-old man who complained of visual disturbance for 1 day. He had a history of atrial fibrillations for 8 years. And when he admitted, he underwent a brain MRI. On diffusion-weighted MRI, a multifocal acute infarction is visible on the left parietal and temporal lobes, suggesting embolic infarction. So he underwent cardiac CT, and on cardiac CT, you can see a thrombus in the left atrial appendage, suggesting that the thrombus was the cause of embolic infarction in this patient. So how should we manage this patient? A patient with atrial fibrillation have a 5-fold higher risk of stroke when compared with normal healthy population. The left atrial appendage is the source of a thrombus in up to 90% of patients with non-valvular atrial fibrillation. Oral anticoagulants are the first-line therapy for prevention of stroke. But if the patients can't take lifelong anticoagulants because they have a bleeding risk or other medical conditions, then how should we treat those patients to prevent risk of stroke? Transcatheter artery closure is one of alternative to prevent stroke in selected patients with non-valvular atrial fibrillation. So, are LAA devices really effective in preventing stroke in patients with AFib? Many studies supported the use of LAA devices to prevent stroke in selected AFib patients. This first randomized clinical trial was published in Lancet 2009. And according to this trial, Watchman therapy was non-inferior to warfarin in the prevention of stroke and death. Watchman therapy showed a 38 reduction for the primary efficacy when compared to warfarin therapy. Then what about the long-term result using LAA devices? Reddy et al. Reported long-term data of PROTECT AFib trial in JAMA 2014. And according to their data, Watchman therapy showed a significant reduction for the primary efficacy endpoint compared to conventional warfarin treatment. As shown in the slide, two curves diverged over the time. In addition, Watchman therapy also showed a significant reduction in all-cause mortality compared to warfarin treatment. And moreover, recent U.S. surveillance data was reported after FDA approval of LAA closure in JAC 2017. A total of 3,800 consecutive patients with AFib who underwent Watchman therapy were enrolled and followed to assess the procedural success and complication rate. This data showed that the overall complication rate was less than 2%, which was very low. Based on the previous scientific evidences, recent AHA guideline recommended as array occlusion may be considered as an option to prevent stroke in patients with AFib who have contraindications to take lifelong anticoagulation. But array occlusion is currently recommended as class 2B, level of evidence B, which means to be required more evidences. Here are currently available array occlusion devices, and Watchman, implanted cardiac plug, and MLH devices are currently all available in Korea. From now, I will briefly explain how we can do the occlusion procedure. First of all, proper measurement of RAA is the most crucial step for RAA device occlusion. So TE is reference standard imaging to determine the size of RAA and choose the right size device for the procedure. First step is an appropriate septal puncture, and TE is important to guide an optimal puncture site. After septal puncture, we change the delivery sheath, and device is pushed into the sheath and check the stability. Then delivery sheath will be introduced into the RAA and positioning to deploy the device. After that, we gently push the device to come out into the lobe and pull back the sheath to deploy the disc. Before detaching the cable, we should check whether the device was located and deployed in proper position based on angiographic and TEE criteria. Angiographic criteria are tire shape of lobe, concave shape of disc, and separation between disc and lobe. At least 2/3 of ACP or amulet lobe should be located distal to the left circumflex artery as TEE criteria. For RAA device occlusion, TEE is currently used as a reference standard imaging modality for pre- and post-procedural imaging. However, because of the excellent image quality, CT has emerged as a less invasive alternative to TEE for pre- and post-procedural imaging. Pre-procedural imaging is key to identifying contraindications, accurately sizing the device, and minimizing complications. CT is comparable to TEE for the detection of intracardiac thrombus. CT can also be used for the delineation of complex RAA anatomy, measurement for device sizing, and evaluation of pulmonary venous and extracardiac structures. The exclusion of thrombus is very important because a thrombus in the RAA is an absolute contraindication for the use of RAA devices. So then how accurate is cardiac CT for the detection of thrombus? According to previous reports, CT is a very sensitive non-invasive modality for detecting intracardiac thrombus. On CT, we can easily see various shapes of filling defects in the left atrial appendage. However, it is sometimes difficult to differentiate between a thrombus and blood stasis. This is because array appendage can have various variations in their morphology. If you want to more accurately differentiate between thrombus and blood stasis, one method is to add an additional delayed phase scan. Blood phenomena appears when array dysfunction causes an incomplete mixing of contrast agent and blood. Therefore, the delay phase scanning will allow for the complete mixing of contrast agent and blood. In the delay phase scan, a filling defect caused by blood stasis would disappear like this case. CT can provide accurate measurement of the LAA ostial diameter, landing zone diameter, and LAA length, which are crucial for accurate sizing of the device. At CT, the landing zone is identified on the long axis LAA view. For the Watchman device, the landing zone is located 10 to 20 mm inside the LAA from the Coumadin ridge. The landing zone diameters for the Watchman device are measured on an en-face view CT image obtained at the line that connects the LAA adjacent to the left circumflex artery to the point 10 to 20 mm inward of the Coumadin ridge. The maximum landing zone diameter is used for the Watchman device, and a perimeter-derived diameter is used for the implant cardiac plug and amulet devices. After LAA device occlusion, patients usually start or continue oral anticoagulation therapy for 30 to 45 days, which is thought to be the time needed for device endothelialization and stabilization. A TE is used as standard imaging to exclude an intracardiac or device-related thrombus or peri-device leak. CT can also accurately evaluate post-procedural complications such as intracardiac thrombi or peri-device leakage. Let me show you a case. Here is a case of a 64-year-old man with AFib and stroke. He had a history of atrial fibrillation for 10 years. He was recently admitted because of stroke and upper GI bleeding. To prevent recurrent stroke, he underwent LAA device occlusion using Watchman. In TE, Watchman device was stably located within the LAA, and there was no visible jet flow around the LAA device. On follow-up CT, LAA was completely isolated by Watchman device, and there was no device-related complication. Here is another case of 80-year-old man who underwent LAA device occlusion using Watchman. In immediate post-procedural TE, peri-device leakage was detected, and the maximal width of the project was measured 3.5 mm. On follow-up cardiac CT, you see thrombus with contrast leakage into the LAA. However, the patient is doing well with no special events during the follow-up period. Recently, new sophisticated software with machine learning algorithms was developed to select the best implants device size and location. This figure illustrated how CT-based software algorithm can predict device interaction with LAA anatomy. These advances allow CT imaging data to show how devices will interact with unique patient anatomy in attempt to predict clinical outcome. There are many considerations for the use of cardiac CT imaging in pre or post-procedural imaging. Currently, cardiac CT is not allowed for either the use of initial evaluation of intracardiac structures or detection of intracardiac thrombus. Presently, there is no standardized imaging protocol. The choice and optimization of a scanning protocol is needed, which accounts for scan range, scan delay, volume of contrast media, and so on. Cardiac CT imaging has a lot of advantages compared to other imaging modalities. But we have to keep in mind that cardiac CT imaging has fundamental disadvantages, including radiation dose, use of iron contrast media, and so on. In summary, transcatheter artery closure has emerged as a feasible alternative to prevent stroke in selected patients with non-valvular atrial fibrillation who cannot tolerate long-term anticoagulation therapy. Currently, TE has been used as the reference standard imaging modality to assess the anatomy for array device and to provide intra-procedural guidance. However, there has been a big improvement in the CT technologies for cardiac CT imaging. Through these developments, the imaging role of cardiac CT has been greatly widened. Cardiac CT can be used for detecting potential cardiac thrombus in selected patients indicated artery closure, or it can be used pre or post procedure assessment for artery closure. However, we should be aware of the limitations of cardiac CT, and we still need large evidence-based clinical trials and validations to find how comes out this technique in the future for the effect on the diagnostic and therapeutic efficacy in clinical routine, and finally for the effect on health outcome and cost. Thank you for your kind attention.
Thank you, Professor Jin Ho, for your comprehensive presentations about the imaging assist for LAA occlusions. So coming up next, I would like to introduce the Associate Professor Sung Ho Wang, my co-moderator yesterday. Professor Sung Ho Wang comes from the Korea University's Annam Hospital, and he also has many publications in radiology and cardiovascular imaging. So today, Professor Sung Ho Wang will present with us about the topic, how imaging assisted for RFA. So Professor Sung Ho Wang, please.
Good morning, ladies and gentlemen. Thank you for attending the reprise course 1 of the morning session. I'm Dr. Hwang, a professor of Korea University. I worked at Korea University Annam Hospital. The topic of today's presentation, cardiac imaging for RFA. The aim of this presentation is to update you on imaging for electrophysiology intervention. Let me start off by introducing RFA. Radiofrequency ablation. RFA is a method which makes iatrogenic tissue destruction with heating tissue. Recently, the RFA has succeeded in the management of cardiac arrhythmia, especially atrial fibrillation with intervention. So today, I'm going to talk about cardio imaging and RFA for AF, atrial fibrillation. There are three main things deals within my talk. First, the background. Next, the current situation, and lastly, the future implication. First of all, let me introduce the background, arrhythmia. Arrhythmia means irregular heartbeat generally, and it is associated with heart failure, stroke, and cardiac death. And depending on the origin, arrhythmia has usually two types: post-supraventricular arrhythmia and the second ventricular arrhythmia. And so atrial fibrillation is a kind of supraventricular arrhythmia. AFib is characterized by the irregular and rapid beating of atria, and it is a common supraventricular arrhythmia in the practice. And the instance of atrial fibrillation continues to increase with aging. Clinically, the AFib may have a major impact on the patient prognosis. It can double the risk of stroke in elderly patients, and sometimes it may be associated with increased mortality in the heart failure. For these reasons, many researchers have studied to control the atrial fibrillation. Now, let's review the mechanism of AFib. There are so many materials and conditions related to AFib development in the world. To be honest, its complex mechanism AFib has not been understood yet. Nevertheless, several researchers have suggested that ectopic electric signal and electrical signal circuit can develop and aggravate the AFib. In 1998, Michel Esquer, a French cardiologist, reported a very important thing to NEJM. He found that the ectopic electric signal triggered AFib, and the signal developed in the pulmonary vein commonly. The pulmonary vein is a vessel which connects the left atrium, and it delivers blood from lung to heart. In most cases, people have full pulmonary veins with two on each side, left and right. If every side consists of a superior and inferior pulmonary vein. Some cases have a variation of pulmonary veins. As you can see, there may be an unusual accessory pulmonary vein from left atrium, or left pulmonary vein has a common trunk, including the superior and the inferior pulmonary veins. The pulmonary vein has a muscle sleeve near the left atrium, and at the junction between the pulmonary vein and the left atrium, heterogeneous tissue composition from the muscle sleeve can make the ectopic electric signal related to AFib. In the RFA, aberration lines surround the pulmonary veins and separate them from the left atrium electrically. And the electric isolation helps to prevent the interruption from ectopic electrical signal of a pulmonary vein in the cardiac conduction system. It is the aim of RFA in patients with atrial fibrillation. Next, let me move on the RFA history briefly. In 1991, Cox possibly succeeded surgical RFA. In 1996, Esquer performed non-surgical RFA successfully. And in 2012, experts concluded that the RFA is an effective and reasonable treatment in patients with drug-refractory atrial fibrillation. In 2012, HLS, Heart Rhythm Society, and different experts made a common consensus statement about aberration RFA in patients with AFib. They suggest RFA for management symptomatic AF has recommendation class 1 and evidence level A. They means that RFA management is reasonable in management of AFib. So here you may be wondering why RFA needs cardiac imaging. The answer is that RFA has evolved into catheter-based procedure rather than surgery. So catheter ablation is more common rather than RFA. Catheter ablation is essentially an invasive procedure, so it is necessary to evaluate and confirm the catheter insertion position and location in the heart. The catheter insertion position usually includes the left atrium, right atrium, coronary sinus, and pulmonary veins, so very sensitive and compressed heart structures. In particular, 3D mapping system of catheter ablation help the procedure to be safe and effective. The 3D mapping system has a magnetic component which can detect and determine the location of a catheter. Then merging the catheter location into 3D cardiac images provides real-time navigation during the procedure. So it enables the operator to handle the catheter delicately. This 3D mapping system requires detailed cardiac imaging data, and only CT and MRI data can be detailed enough to make the 3D mapping system. Today, we'll mainly focus on the CT images for 3D mapping system of catheter ablation. Technically, a cardiac CT for 3D mapping system must meet two major conditions preparing the catheter ablation. First, good image quality even in the arrhythmia. Second, appropriate contrast enhancement of heart chambers. I recommend a retrospective ECG gating for CT scan in patients with AFib. From the CT scan data covering the entire cardiac cycle, we can select the best to minimize the artifact from arrhythmia of AFib on CT images. But when used retrospective ECG gating, we should consider the radiation exposed to the patient. The second condition of cardiac CT for RFA is contrast enhancement. Cardiac CT for RFA needs appropriate contrast enhancement in the coronary sinus, right atrium, beyond the pulmonary vein, and the left atrium. We performed a cardiac CT for RFA with a dual phase contrast injection protocol because contrast and satellite visit processing appears like the heart chambers and it can visualize them. Sometimes additional CT scan may be useful before the procedure. Please look at these different phase CT images. One is atrial phase and the other is delayed phase. Usually atrial phase CT shows contrast filling defect in the appendage apex mimicking the thrombus. But sequential delayed CT scan shows a weak but homogeneous contrast enhancement, and it can help us to differentiate the thrombus from broadostasis with contrast filling, especially in the left atrial appendage. So the delayed CT scan has another advantage in evaluating congenital anomaly. Some people may have congenital anomalies like the atresia of coronary sinus. Let me introduce my experience, atresia of coronary sinus. A 57 years old man admitted into our institute and underwent cardiac CT before the catheter ablation of AFib. The 3D CT image shows a large coronary sinus from the left prostate superior vena cava SVC. This coronary sinus has no ostium into the right atrium, but it has a normal drainage channel to the left atrium. So, in this case, after discussion, the cardiologist inserts the catheter through the left prostate SVC into coronary sinus. It is an unusual route, but we can realize that the correct information provided by CT images saves the procedure time and improves the procedure safety. If you are unsatisfied with weak contrast enhancement on delayed CT images, the dual-random CT may be a good solution. As you can see, low-end CT images may improve image contrast, emphasizing iodine component even in the delayed CT scan. The pre-procedural cardiac imaging is essential for successful catheter ablation of APF, and the role of cardiac imaging keeps going after catheter ablation. As all procedures, the catheter ablation can result in the complication beyond the structural change and deformity of the heart. Cardiac imaging with the CT and the MRI is very useful in the evaluation of a post-catheter ablation status. Our main change of the heart after ablation is the shrinkage of the left atrium. The size of the left atrium decreased remarkably after ablation. This structural change seems that the left atrium returns to normal with the maintained normal sinus heart rhythm. But as a negative aspect, the catheter ablation makes the left atrium become stiff with the left atrial wall tissue injury, and the stiffening the left atrium may result in the dilatation, pulmonary veins, and left atrial appendice. Let me show the case with the left atrial appendice aneurysm after the ablation. As you can see, 1 year follow-up MRI after ablation shows a remarkable dilatation of left atrial appendice. Its volume is over 20 milliliter, and the echocardiograph shows a spontaneous echo contrast with the blood stasis in the large left atrial appendice. It seems to be a risk factor of appendage thrombus, even in maintained normal sinus rhythm. Next, let me show the very severe complication, the Asci injury after ablation. If a patient presents a fever and dyspnea within 1 month after the ablation, this is a very dangerous sign related to Asci injury. At the time, we should perform the chest CT immediately to evaluate the fever course. Please look at these CT images. We can notice the air bubbles in the left atrium near the esophagus. This finding indicates the atrioesophageal fistula after ablation. When interpreted chest CT and patient suspect the esophageal injury, understanding ablation procedure and ablation lines help us detect abnormal findings such as air bubbles near the pulmonary veins along ablation lines. It is very useful findings in diagnosis of atrioesophageal fistula. Let's move on the future implication in the catheter ablation. We will see various technical advances soon. First, the RFA may be replaced with cryotherapy in the management of APF. Some people call it the wall of fire and ice. Now, various clinical trials comparing the treatment result between cryotherapy and RFA are coming out. But no matter who wins in this war, anyways, the catheter-based procedure will need the excellent cardiac imaging that we provide. And the cardiac MRI is another important issue for catheter ablation in APF, and cardiac MRI enables the comprehensive analysis of anatomy, tissue, and blood flow, which can help decide the various treatment strategy. For example, left atrial fibrosis determined with MRI may be associated with recurrent APF after the operation. In 2018, one World Center study reported that the late cardiac enhancement LGE MRI was useful in predicting the response to catheter ablation. The researchers suggest the Utah classification for the evaluation about left atrial fibrosis by LGE, and depending on the extent of LGE, left atrial fibrosis can be divided into 4 degrees, and they report that Utah stage 1 minimal LA scar was associated with a high success rate of operation in patients with AFib. To summarize what I have been talking about, the RFA has evolved into catheter ablation for the management of AFib, and the cardiac image-based 3D mapping system helps successful catheter ablation with real-time navigation. Furthermore, advanced cardiac imaging helps us understand and assess the impact of catheter ablation on the heart. That ends my talk, and thank you again for the opportunity to be here with you. Thank you very much.
Thank you very much, Associate Professor Sung Ho Wang. So I think right now we come to Q&A discussions. As we have a few minutes for a couple of questions. So as we're looking at the Q&A chat, we have one question for Dr. Jin Ho. Is there a great system of slow flow in CT or of LAA? And slow flow that's about blood stasis, and if there is slow flow, is this a contraindication for RFA or maybe a microthrombin not seen on CT? Thank you.
Yeah, thank you for the question from Professor Ling Ting Wo. As I know, currently CT has no generalized specific grading system for slow flow blood stasis, while TE has. And as you mentioned, fresh thrombus or microthrombi can be missed by CT. And it can also happen even though we use the TEE. And currently, blood stasis is not a contraindication for RFA procedure.
So, do we have any other comment or questions, Professor Zinho?
Yeah, while we wait for a question from the online audience, I have a few questions for the speakers. First, I would like to ask to Dr. Zhang. Actually, I have 2 questions for you. For CTO treatment, you talked that functional assessment is important. And so for functional assessment, what kind of imaging modalities did you use in your center? This is the first question. And did you provide any routine standardized reporting system, including CT scores or any functional information using CT in your the Center for CT or treatment guidance?
Okay, thank you, Professor Her, for your question. And I would like to answer the first one. Cardiac MR is routinely performed in our institution for the functional evaluation of coronary total occlusion, especially to see whether there is a salvageable myocardium within the territory. However, with the hardware development of CT myocardial perfusion imaging plus late iodine enhancement, some cases nowadays are replaced by CT perfusion plus late iodine enhancement for the one-stop imaging for anatomical as well as the functional, because the patient does not necessarily have to undergo 2 examinations on different days, it's easier to handle the cases within one examination. But one prerequisite is the renal function is okay for the patient, because for CT perfusion we have to plus CT angiography we have to inject approximately 1 millimeter contrast medium, and the radiation dose will be a little bit more higher than what we routinely perform for CT coronary angiography. So we will selectively choose the patient for CT perfusion evaluation or cardiac MR evaluation. And for the second question, the complexity score, I think in my institution it's only for the research purpose, not integrated as the routine work tool, because I think the interventional cardiologists, they're sometimes more confident about their interventional skills rather than they think they can do it all.
Thank you for your answer.
Sorry, maybe I have a small question for Associate Professor Hoàng Anh Tiến. So follow up about the AI in the CTO lesions. Do you have any applications of AI in your hospital? For example, for CTO lesion or for LAA occlusion? Thank you.
Yes, thank you very much for the question from the chairman. Your question is very interesting because they're applying the artificial intelligence, especially in the coronary arteries. Intervention is very hot topic in now, and it's very difficult to apply the whole. It means the autonomous artificial intelligence is very difficult. Just now is that we apply the SEMI, the autonomous procedure for doing the cardiovascular intervention in our universities. And now we have the plan, the project to use the artificial intelligence in doing in the cardiovascular intervention. For example, do some the simulation for the medical student. And the next, we plan to buy some equipment for the CAD lab to do the semi-autonomous interventional cardiology. So as you see the other topic, the other speakers that in this session, CTO is very complex. This is the more complex procedure for the interventionist like me. And so I'm very admired and very interesting in the topic of the CTO from Dr. Brewer. I think it's very helpful when use the CTA before we do the CTO. And so I think that with the CTO we cannot use the artificial intelligence in interventional cardiology. So I think with the near future we will try to apply with the helping from the CTAs and other modern technique. Thank you.
Thank you. And now we have a small question, another question from Professor Minh Tinh to Dr. Professor Jin He. So, to your experience, did you find higher frequencies of stroke in patients with slow flow in CT?
Yeah. It's definitely who had a slow flow. The patient had high chance of stroke because slow flow is a dynamic situation. It means that LAA has a dysfunction and it has a higher chance to have a thrombus. Therefore, the patient with slow flow had a higher chance of stroke compared to general populations. So I have a quick question to Dr. Huang. For RFA imaging guidance, you mentioned about the MRI as an imaging modality for RFA guidance. So what is the advantages or disadvantages to use MRI as an imaging modality for RFA guiding?
Thank you for your question. MRI is a very potential, very promising method, but its best advantage is the comprehensive analysis. MRI can provide anatomy, tissue characteristic, and blood flow hemodynamics. These information cannot be provided by from the echo and cardiac CT. But this MRI also has a disadvantage. It is cost and the time. Some people, especially in the ICD, a pacemaker and the defibrillator, but the patient with the ICD is now has considered as a contraindication of MRI. So some people cannot properly underwent the MRI. So I think, in conclusion, MRI has a promising and a high potential utilization, but we should keep in mind that MRI also has some limitation, especially cost and the contraindication. Thank you.
Thank you. I think it's time to close the session because of time. And I would like to close this session by thanking all the speakers and all of those who have taken part in this session. Thank you for joining this session, and I hope you have a wonderful day. Thank you. Bye.
Thank you. Thank you. Bye-bye.
Thank you, Dr. Prang, and all speakers.
Thank you, all speakers. Thank you so much.
Yeah.
Bye-bye.
Thank you. Bye.
One day, we can all stay healthy, and no one suffers from hunger. We will only realize this vision together. Together, we will come back stronger. Together, for a future with health for all, hunger for none.
My journey continues, and I know I'm not alone. Because together we can make a difference every day.